Welcome to the final day of the 72nd GOGS and Georgia Section ACOG educational meeting. I'm Gretchen Kuntz, your newly installed 2023-2024 president, and I will serve as your moderator for today. So let's get started. A few reminders. If you have not already done so, please set all of your electronic devices to mute or silent. This is a breakfast lecture, so we want to be extra considerate to our presenters and colleagues today. So if you'd like to have a discussion or need to make a phone call, please step outside. If you've not already done so, please log on to the GOGS meeting platform. You can see, or it was on the screen just a minute ago, but I know it's out at the front desk. There's a QR code and link. Once you've logged on, you'll need to click on the daily check-in and faculty's PPTs button. Select the correct day, then click on the check-in box to acquire your daily CME. This is also where you'll find the speaker's information and PowerPoints. You can find instructions on how to download your CME certificate through our GOGS meeting platform. After logging in, look for the green CME button. The link will be available this morning. Please wait until the last lecture has completed today before proceeding. There will be a 5-minute question and answer session after each lecture session today, so please hold your questions until the end. If you would like to ask a question, remain in your seat and raise your hand, and Kate will come find you with a microphone. If you're attending virtually, you may press the raise your hand feature or enter your question into the Q&A box. And finally, for those of you that are here that are not members or currently members of the Georgia OBGyn Society, as a newly installed president, I welcome you to join the society. We have a very exciting year ahead of us, a lot going on this year. And as always, if you have any questions, please do not hesitate to ask me or one of the staff members that's here today. All right, let's get started. So I'd like to introduce our first speaker today, Dr. Paul Nyirjesy. He is professor of obstetrics and gynecology at Sydney Medical College at Thomas Jefferson University in Philadelphia. He's also the co-director of the Jefferson Vulvovaginal Health Center and interim division chief for the Division of Gynecological Surgical Specialties. He graduated from Amherst College. He obtained his MD degree from Georgetown University. He then did an internship at Thomas Jefferson University and a residency in obstetrics and gynecology at Thomas Jefferson University. He finished his fellowship in infectious diseases at the Department of Medicine at Temple University in Philadelphia. His research is method for treating vulvar vestibulitis, and he has obtained multiple teaching awards as well as top doctor awards. He's going to talk to us today on managing chronic vulvovaginal diseases, lessons learned from a tertiary care center. So thank you, Dr. Nyirjesy.
Thank you. For some reason, I can't start the video. It says the host stopped it. Can you hear me?
Yes, we can hear you.
Okay, so I can't start the video. It says that the host has stopped it. Sorry to have a glitch there.
I didn't change anything. You had it shared.
Yeah, and then I had to log out to share my screen, and then I had to log back in.
Okay, stand by. All right.
There we go. Good morning, everybody. Sorry about the glitch to get started. First of all, I'd like to thank the organizing committee for having invited me to speak to you this morning. I'm sorry that it's virtually. I've heard that the weather in Hilton Head is lovely today, or it has been this weekend. What I'd like to do before we start is I just want to share with you my conflicts. I currently am consulting for OBGyn, and I've done some speaking for CEFID. None of this will actually be relevant to the lecture today. So my background has been shared with you, but I just want to go over it again, partly because it'll explain how I ended up doing what I do. So from 1985 to 1989, I did a residency in OBGyn Wanted to stay in academic medicine, and so I did, but I didn't want to do a standard subspecialty, so I did an infectious disease fellowship in the Department of Medicine at Temple. And really, as a research project in 1991, started what was at the time the Temple University Vaginitis Center. I had no clue what I was doing, and meanwhile, I was getting patients coming down from Manhattan and coming up from Washington, D.C. And then in January 1992, I was fortunate enough to meet Jack Sobel, who at the time was the head of infectious diseases at Wayne State University in Detroit. I think that's when I really started to understand what I was doing and how to approach treating patients with chronic vaginitis. And ever since then, the bulk of my career has been focused on treating women with chronic vulvovaginal diseases, and I'm the current co-director of the Jefferson Vulvovaginal Health Center. So this is a tertiary care center for women with chronic vulvovaginal complaints. It was established in November 2019. We have 5 providers, 2 gynecologists with specialized training, and 3 dedicated nurse practitioners. And to give you a sense of volume, we see about 2,000 new patients every year. And so this is a really busy program. It shows you how much of a need there is to see to have providers who are able and willing to see women with chronic vulvovaginal diseases. And so for today's talk, I'd been asked to speak some about vaginitis, some about vulvar diseases, and I thought that I would try to tie the two together by talking about some of the lessons that I've learned over my 30-year career. And so I'd like to start with this table that Jack Sobel put together in a paper that was published in 1990. And in this table, he had what he called the pitfalls in treatment of vaginitis. Number 1, patient self-diagnosis and treatment. Number 2, failure to see the patient, relying on the telephone. Seeing the patient but not examining them. Failing to examine the vulva and the vestibule. Failing to perform appropriate laboratory tests. Treating things like E. coli, Enterococcus, Gardnerella, and other normal flora as pathogens. Using shotgun therapy. Guessing at therapy. Overusing topical steroids. Relying on a pap smear to make a diagnosis, and failing to recognize that topical therapy may exacerbate symptoms. And so Jackie wrote this paper in 1990. It was just his thoughts about the pitfalls that many providers fall into. And since that paper was published, there's actually been a fair amount of data to support that these pitfalls actually exist. And what I'm going to do is take you through some of them. So the first pitfall I think we all need to recognize is that self-treatment and for vaginitis, particularly for yeast infections, is one of the biggest pitfalls that women fall into. The purported advantages are that it's very convenient. It gives a woman ability to initiate therapy quickly. In an era where we're constantly seeking ways to empower women, it's thought to be very empowering. And when people have looked at some cost-benefit analyses, there's thought to be a reduction of healthcare costs, $45 million in direct cost savings, almost $19 million in indirect cost savings in this one 2000 estimate. But meanwhile, there are huge questions about accuracy of diagnosis. And Darren Ferris, who's at the Medical University of Georgia, was the first one to raise concerns about this. And in 2002, he organized a group of 5 of us to look to see just how accurate women were to self-diagnose themselves. And so this was a prospective 5-center study. What we did is we went to all the local pharmacies and we told the pharmacists, if you see a patient who's about to buy an over-the-counter antifungal product, please give her this pamphlet. And what this pamphlet offered her was a free evaluation within 24 hours of her phone call to see what she actually had. And so we offered immediate evaluation of their symptoms. Over 2 years, 94 women were enrolled. And I think the point of that number is it shows you how well accepted self-treatment is. In the Philadelphia area, where we were one of the sites, we had lots and lots of pamphlets that were given out by the local pharmacies. I enrolled 20 women, which made me the second author on this paper. But meanwhile, the bottom line was that self-treatment with antifungals would have been inappropriate in about 60% of these women. And so self-treatment and self-diagnosis is very inaccurate. So then maybe if you shouldn't be relying on self-diagnosis, maybe the telephone is accurate. And Jandel Allen Davis in Denver did a study looking at this. And so this was a study of 485 women who were diagnosed over the phone by a registered nurse. Of these, about half were seen within 24 hours for evaluation. She used a statistical test called the kappa value to look at the telephone diagnosis in comparison to the actual diagnosis. And she showed that there was poor agreement beyond chance for the diagnosis of BV, candidiasis, and trichomoniasis. And so I'm not going to say we never use the telephone to diagnose a patient. I think we all have to. It is a time management concern, but we need to recognize that the telephone is very inaccurate. So then patient comes in, and I think that sometimes they don't even get a basic exam. And one of the things that the CDC emphasizes in the STI treatment guidelines that were published a couple of years ago is that obtaining a medical history alone has been shown to be insufficient for accurate diagnosis of vaginitis and can lead to inappropriate administration of medication. And so what a vulvovaginal examination really should consist of is inspection of the vulva, the vagina, and the cervix. And examining the vulva, and especially the vestibule, are just key to come up with an accurate diagnosis. So what was the vulva when I was a medical student and a resident? It was a structure that I went through to put in a speculum, to get a pap smear once I could find the cervix. And I think that many providers never get beyond that. But when it comes to the non-infectious causes of symptoms, looking at the the vulva specifically will give you important information in terms of coming up with an accurate diagnosis. And then what's recommended is to do office testing on every patient with vulvovaginal symptoms. And the office testing consists of the vaginal pH, a whiff test, a wet prep, and a KOH smear. So meanwhile, it turns out that there's always been concerns that providers aren't doing these pretty basic laboratory tests. And so the first paper came out of Pittsburgh, Harold Weisenfeld, who reviewed the charts of 52 women who had been referred to his tertiary care vaginitis center for evaluation. So this is not what he did. This was looking at the records of the patients who came to see him. And he found that whiff and vaginal pH measurements were performed rarely, 3% of the time. 42% of the physicians didn't use a microscope at all, and 54% of the visits where a medication was prescribed had an inadequate evaluation. So this paper was published in 1999, almost 25 years ago. Have we gotten any better? And so the group in Pittsburgh just published a few years ago another study. So this was a prospective study of 303 women who were seen at a UPMC-affiliated medical center for symptomatic vaginitis. And they compared office-based practice to standard of care laboratory testing. And they found that point-of-care tests, including vaginal pH, potassium hydroxide whiff tests, and wet mount microscopy were rarely performed. And 42% of the women having vaginitis symptoms received inappropriate treatment. So 1999, the number was 54%, same geographic area. Now the number is 42%. The numbers are actually a little bit worse than you would think, because all the providers knew that they were in this study and that the charts were going to be evaluated. And meanwhile, 42% of the women had an inappropriate workup. And so what is the standard of care? And I'd like to take it through by condition. So first of all, in terms of infectious vaginitis, we have this slide that shows trichomonads. Very satisfying when you see these protozoan organisms floating around on a wet mount. But it turns out that a wet mount is actually not that good. The sensitivity in study after study after study is about 50%. So what other tests are available? Well, there's the AFFIRM test, which is also known as the vaginitis panel by Becton Dickinson. Many labs offer this, and I'm sure that many of you have ordered this because it's available and widely recommended by the labs. it turns out that the Affirm test is actually not very good. It's at best 60% sensitive for trichomonas. Culture has been the gold standard. The nice thing about culture is there are no false positives. The downside is that it's not always available. There can be a limited shelf life for the medium. And so the gold standard now is nucleic acid amplification testing. And the nice thing about it is that the same swab that you're using for gonorrhea and chlamydia testing can also be used for trichomonas testing. With bacterial vaginosis, the standard has been Amsel's criteria, seeing a white or a gray homogeneous discharge, seeing that the pH is elevated, finding that the whiff test is positive, and finding clue cells on microscopy. Technically, need 3 out of the 4 to make the diagnosis of BV. This is a nice example of clue cells, and hopefully you can see these stippled cells where the border is kind of obscured by all these coccobacilli. This is a phase contrast showing the same thing, and I think it's helpful to look not only at the clue cell, but also look at the background of bacteria. And you'll see that there are very few rods. What rods there are short, stubby little things. And so if you see that the whole vaginal microbiome is very disordered, you should be thinking that the patient may have bacterial vaginosis. So the gold standard for testing has been the Nugent score. And in any research study, they should be doing the Nugent score. What it does is it semi-quantitates different types of bacterial morphotypes, and it gives the Gram-Stain a score of normal, intermediate, or abnormal. So the Affirm test also offers a test for Gardnerella. They say that they detect an abnormally high level of Gardnerella, but it turns out that the problem with the Affirm test is there's a false positive rate, which in some studies is as much as 40% false positive. And so if you have a patient who keeps having repeatedly positive Affirm tests but has no symptoms, this could easily be a false positive Affirm test. The CDC says it's more accurate if you combine it with vaginal pH and whiff tests. The problem is that most providers don't do vaginal pH and whiff tests. And an Affirm test without a pH, again, overcalls bacterial vaginosis. And then nowadays in the United States, there's nucleic acid amplification testing for bacterial vaginosis. The way to think about it is that it's an expensive version of doing a Nugent score. So they semi-quantitate different bacteria, and they have different algorithms to decide whether it's consistent with BV or not consistent with BV. But the good news is that with these newer tests, they are actually quite accurate in reproductive aged women, and probably accurate in women who are not reproductive aged. And then finally, we have the KOH, or we have vulvovaginal candidiasis. And here with the KOH, there's no great published data on performance. The performance is very provider specific. And so I think the study out of New York captures how inaccurate a KOH can be. So this was a study of 61 patients in an OBGyn clinic at Cornell who had been told by a resident that they had a yeast infection. They had all undergone office testing, and they then did samples for yeast culture and PCR testing. And it turns out, and keep in mind that yeast culture is much more sensitive than microscopy. So 100% of these cultures, or close to 100%, should have been positive. It turns out that only 33% of these women had a positive culture. And so in this very busy New York-based residency program, it turns out that 2/3 of the time when a patient was being told she had a yeast infection, she didn't have yeast in her vagina at all. So a study of this sort, I think we've all been through residency training programs or other training programs for those who aren't physicians. It's always easy to blame the intern or blame somebody with less experience. And one of the things that they looked at was the level of training, and it turns out that a higher level of resident did not improve the accuracy of the diagnosis. And so it's just important to realize that when you're reviewing someone else's chart or someone else's care, just because that other provider has said that the patient has a yeast infection based on microscopy doesn't necessarily mean that she actually had a yeast infection. And so again, with the KOH, no great published data on performance. It's provider specific. It's also not that sensitive, and you should expect a sensitivity of about 50%. When we've looked at our own sensitivity rate, it's about 52%, so we're right in there. But the false positive rate should be low. And so if you're seeing somebody and you think that you're seeing yeast on microscopy, a yeast culture should be positive. So just a couple of pictures. So this is a picture from that Ryan Sobel, my co-director, took. You see these two things. One of them, this long, stringy thing. Second, this little oval. The question is, which one of these is yeast? It turns out that it's actually the thing on the right, and the thing on the left is actually artifact. This is an example of hyphae. The things to notice with hyphae is how they're hollow. They have a fairly consistent diameter throughout, and every end and every projection is rounded. Another example of fungal elements, a little bit out of focus, sorry about that. Another example of artifact. So notice how the diameter changes. The inside of this thing, there's all sorts of stuff in it. And then if you look at the top of this, it's all pointy and jagged. But you can see it's the exact same size as hyphae, and it kind of emphasizes the fact that it's really easy to overdiagnose yeast based on microscopy. And then with yeast, certain types of yeast don't produce hyphae. Candida glabrata and Candida parapsilosis, the number 2 and 3 causes of yeast infections, don't produce hyphae. And so to diagnose it with microscopy, you have to be able to recognize blastospores, which look like little snowmen under the microscope. And so there are other tests for yeast infections. The limitations with nucleic acid amplification testing, which has kind of swept the United States, is that they only test for certain species of yeast. And species are sometimes lumped together, and that's really important because Candida albicans, for example, tends to be very sensitive to various azole medications. Other types of yeast, which may fall into the same grouping, can sometimes be quite resistant. And so one of the disadvantages of yeast PCR is you don't always get the specific species. Not all of the tests which are available have been FDA cleared. And so if you're using yeast PCR testing, you should really be sure that you know what the performance characteristics of that specific test are. And then yeast PCR tends to be more expensive than culture. And so the nice thing about PCR testing is that it's widely available, but there are definitely limitations to it. And just as one example, in the past 3 months, we've had 4 different patients with Baker's yeast infection, Saccharomyces cerevisiae. There isn't a PCR test out there that tests for Saccharomyces. It's just thought to be so uncommon. And so the best test is a yeast culture. It corroborates microscopic findings. It's more sensitive than a microscope. It allows for speciation of the organism for a broad range of yeast species. If you choose to do susceptibility testing, which can be helpful in some cases, it makes the organism available for susceptibility testing, and it remains the gold standard in the CDC guidelines. So why is speciation important? Because some of the organisms you grow out may not be pathogenic at all. Not all yeast infections are the same. So for example, if you grow out Candida glabrata, it can be a cause of symptoms, but maybe only 30 to 50% at the time. And then different species are treated in different ways. And so for example, Candida parapsilosis, which is one non-albicans yeast, often responds to fluconazole, whereas Candida glabrata, which is another non-albicans yeast, doesn't respond to fluconazole at all. So another pitfall then is treating normal flora as pathogens. And this used to be an issue when I started out, when a provider would order a bacterial culture and they would just treat the result. And there are now modern versions of it. And so there's this condition which folks are calling aerobic vaginitis, which some labs are aggressively promoting. And the concept is that you need to be testing for group B strep, Enterococcus faecalis, E. coli, and Staph aureus, because those are calling an aerobic vaginitis. There's no evidence that any of these organisms cause any sort of vaginitis. I think Staph aureus, maybe that one might be a little bit controversial, but the others are clearly part of the normal vaginal microbiome. But I see a lot of patients who get this PCR test for aerobic vaginitis, which leads to lots of unnecessary antibiotics. The other modern version of treating normal flora pathogens is testing for genital mycoplasmas. There are 3 of them of interest. Mycoplasma genitalium may be something which causes cervicitis, although it's actually a very controversial organism. But the other mycoplasmas, Mycoplasma hominis and ureaplasma, are not associated with vaginal symptoms, and at least one of those organisms will be present in 70% of normal healthy women. At least once a week, I get a patient referred to me with a chronic ureaplasma infection. She's been treated a lot. Her partner's been treated a lot, and I tell the patient I'm not even going to test for it because that's not the cause of the symptoms. I come up with a different diagnosis, and we focus on the different diagnosis. So what is our overall testing approach? We emphasize in-office examination and testing. We do yeast cultures on anyone presenting with vulvovaginal symptoms. We do Trichomonas vaginalis NAT testing in women with possible STI exposures, or lots of WBCs on microscopy, and also in the women with recurrent BV, because sometimes they don't have recurrent BV, they've got a Trichomonas infection. So with that, I just want to touch a little bit on how to treat the more complicated forms of infectious vaginitis. And so with recurrent vulvovaginal candidiasis, the definition is 3 episodes of proven yeast infections in a year. This is a condition that happens for a number of different reasons, but at least 50% of the time it happens in women who are completely normal, healthy women. No clear underlying cause for why it's happening. And it's easy to trivialize and say, oh, it's just a yeast infection, it's not a big deal. But the estimates are that it actually is a very big deal. About 6 million women a year in the United States are affected, and it's estimated to be associated with almost $5 billion in lost productivity, which actually makes it a very important health condition in the United States, and I might add worldwide. And it used to be that the number quoted was that 5% of women were affected with recurrent VVC. That number was questioned in the past decade, and now people have looked at it because some people felt that that number was way too high. It turns out that the number is probably closer to 7%. So this is actually a relatively common condition. So how do you manage recurrent vulvovaginal candidiasis? Number 1, forget probiotics. They are a complete waste of time. There's no data to show that they're helpful for managing yeast infections. Number 2, get a yeast culture. If you can't get a yeast culture done, do nucleic acid amplification testing. And then if it's positive for Candida albicans, just put them on a long course of treatment to control the infections. If they're not pregnant or not trying to get pregnant, you can give them fluconazole once or twice a week. I use a 200 milligram dose just because it goes through prescription plans easier, but just put them on a long course of fluconazole to control the yeast infections. If they are pregnant or trying to get pregnant, fluconazole is not recommended because it's associated with an increased risk of miscarriage, possibly an increased risk of having a baby with a cardiac defect. So we have patients use topical clotrimazole, just the 7-day over-the-counter cream, twice a week for 6 months. If it's positive for non-albicans Candida, first of all, you have to decide if you think it's the cause of the symptoms. So you have to put it together with the patient's clinical picture. And there what seems to work is boric acid, 600 milligrams vaginally every day for at least a month, sometimes for longer. So one of the things that we found recently is that fluconazole, which used to be very reliable for Candida albicans infection, may not be as effective as it used to be. And just this year, we had a paper published out of our program where we reviewed 970 cases of Candida albicans infections. And we found that clinical resistance is now present about 7% of the women that we treat. 6-7 years ago, the number was maybe 1 or 2%. So resistance may be growing. And this was a retrospective study, so it had its limitations, but it looks as though boric acid is an effective and affordable option. So there are some new drugs for recurrent candidiasis, oteseconazole, which is highly effective, and in 3 large phase 3 studies, after just a 3-month course of this new medication, there's only a 5% recurrence in the 9 months after stopping treatment. The catch is that it's not approved for women in their reproductive years because of safety concerns. And unfortunately, it's going to be primarily women in their reproductive years who are getting recurrent yeast infections. And then there's a Brexafung group, which has also been approved. They did complete a monthly maintenance study. The results have not yet published, but they're part of the public domain, and you can see it on the company's website. It is better than placebo at treating recurrent yeast infections, but it's hard to tell if it's better than maintenance fluconazole. So recurrent bacterial vaginosis, how do we manage that? Number one, forget probiotics. It doesn't seem to help. Partner treatment doesn't seem to make any difference based on 9 different studies, but condoms do. And there's something about sexual activity that increases the risk of getting bacterial vaginosis. Using condoms seems to decrease the risk by about 50%. So one of the things that is not on the slide that I'll do is if I have a patient who's gotten lots and lots of metronidazole but has not gotten clindamycin, I'll give them just a 1-week course of clindamycin cream. The thinking is that by using a different antibiotic, we hit a different profile of bacteria within the vagina that's causing bacterial vaginosis. 40 to 50% of the time, that seems to be a pretty good long-term solution. There was one study that we participated in that just looked at giving patients a long course of metronidazole gel for 4 to 6 months, but there was a high failure rate while they were on treatment, about 30%, and high recurrences after stopping treatment, about 70%. And so now what we do is we give patients initially a course of metronidazole twice a day for 7 days, along with boric acid times 21 days. And then after that, we have them use metronidazole gel twice a week for 4 to 6 months. The concept with the boric acid, by the way, is not that we're trying to change the pH. Turns out boric acid actually is a weak acid. It raises the pH of the vagina. But what boric acid seems to do is it seems to break up vaginal biofilms. And so the concept is we treat with antibiotics and break up the biofilm, and then we put them on maintenance metronidazole gel. The results of this approach have been published by Jack Sobel, and it's much better than just having patients go on maintenance metronidazole gel without that pre-treatment phase. So this is our overall approach to managing chronic infectious vaginitis. A lot of the conditions that we treat are really vulvar diseases. And a lot of what I learned in terms of managing vulvar diseases is from Lynn Margison. If you've never heard her lecture, you've missed out. She's a wonderful lecturer. She's a lecturer. She's up in New England. And so she published, actually she didn't publish, this was at a meeting where we were both speaking. She had a little handout for the New England OBGyn Society where she had written down her vulvar pearls. And so vulvar pearl number 1 was get a good history. Number 2, recognize normal and abnormal anatomy. Look closely to see the diagnosis. Biopsy. Recognize concurrent conditions. One of her pearls is that VVC is overdiagnosed. I think I've already made that point. Meanwhile, an irritant or contact dermatitis is underdiagnosed. Psoriasis is missed. Everything white is not lichen sclerosis. Do not miss lichen planus. Do not be a wimp with corticosteroids. Do not miss cancer. If you see vulvar ulcers, think aphthy. Avoid inadequate follow-up and avoid compliance issues. And what I'd like to do is take you through some of these in a little bit more detail. So this is a patient with a yeast infection, and I want you to kind of ignore the little bit of white discharge that she has, because that could be anything. But if you look closely, the right inner lip is swollen. She's got a little fissure right at 12 o'clock in the vestibule underneath the clitoris. Her vestibule has kind of a blotchy red appearance to it, but her overall anatomy looks completely normal. She's got inner labia, she's got outer labia. If I pull back the hood of the clitoris, I can get a good look at the hood of the clitoris. Meanwhile, this is a patient with lichen sclerosis. The labia minora are completely flattened out, and you can just tell that there's something missing when you're looking at the vulva. This is another patient with lichen sclerosis, and I think it's easy for the eye to be drawn to this white epithelium extending down over her buttocks, up in the interlabial folds, up on the prepuce. But the other things to notice is that on the right side, the fold between her inner lip and her outer lip is blunted. And there's a missing part of the inner labium here. And if I were to try to pull the hood of the clitoris back to get a good look at it, I'm not able to because it's all adherent. This is a patient with lichen planus. In a way, very similar to lichen sclerosis in that you've got the scarring around the clitoris, the flattening of the labia minora, but lichen planus tends to give you much more in the way of erosions, and the white epithelium has much more of a kind of a lacy appearance and looks very different than the white epithelium in a patient with lichen sclerosis. This is another patient with lichen planus, and again, the point, she's on treatment, which is why she looks better, but again, notice the loss of the architecture. So you always want to make a habit, or I always make a habit of looking at the architecture of the vulva when I'm doing the vulvar exam. This is a patient with really bad lichen simplex. The skin is all thickened, you can see all these excoriations, but if you look at her anatomy, the anatomy is actually quite normal. But it's just that the skin is thickened in a very diffuse way because of all the itching and scratching that she's been having and doing. So the other thing is you need to look really closely at the vulva to make a diagnosis. And this was a patient who was having intense pain in the vestibule. And when I looked at the inner vestibule, right at 11 o'clock, she had this red area just internal to it. She had a little bit of white. And there's a little bit of an adhesion in the anterior vestibule, and it made me think of lichen sclerosis. And so I did a biopsy, and the biopsy came back consistent with lichen sclerosis. But it's very easy to miss this. So then let's talk about lichen sclerosis. So lichen sclerosis is a fairly common vulvar condition. The most recent number that I saw in terms of epidemiology is that maybe 1 out of 30 women get lichen sclerosis, which is actually a pretty big number. The diagnosis rests on biopsy, but the biopsy may be misleading. I think sometimes the wrong area may be selected for biopsy. It might be that the pathologist who's looking at it isn't familiar with making a diagnosis. And if you get a biopsy report that says chronic vulvitis, right away, you know, the pathologist doesn't know much about vulvar pathology because that's not even a condition. And there's at least one study that has shown that up to 11% of vulvar biopsy, when reviewed, have been miscategorized for lichen sclerosis. And there can be underdiagnosis of lichen sclerosis, sometimes overdiagnosis. And so if you have a patient who's got a good exam for lichen sclerosis, but it's not confirmed by pathology, you might want to consider a trial of therapy. And I might add, by the way, that I think we've all been taught in our training that to make a diagnosis, you really need to do a biopsy. It turns out that about 2/3 of the experts, including me, don't routinely biopsy somebody with lichen sclerosis. And so it's something that you should consider doing, but it's not always as helpful as you would think. So what's the therapy for lichen sclerosis? Ultra-potent steroids, clobetasol, halobetazol, or betamethasone. We start with daily for at least a month, followed by an extended tapering dose. Skin atrophy is fairly rare. Problems with systemic absorption have not been reported. And sometimes people try what are considered non-thinning anti-inflammatories like tacrolimus. Tacrolimus and also pimecrolimus, which is a related drug, have been studied. And the results with those have been totally unimpressive. And so it's really ultra-potent steroids. The other advantage of steroids is that they may help to decrease the risk of cancer. And so this was a really nice study out of an Australian group, a prospective cohort study of 507 women with lichen sclerosis, who they followed for almost 5 years. And they thought it'd be unethical to look at treatment and cancer prevention, comparing schedule to patients not using steroids. But what they decided to do is compare women who were compliant with their regimen versus women who were non-compliant. And during the follow-up period, and they used a different steroid regimen than what we use, but I think the concept is the same. In the group that were compliant with therapy, not a single patient developed either a high-grade lesion or a vulvar cancer versus almost 5% in the non-compliant group. Symptoms were suppressed much more effectively, 93% versus 58%. The risk of skin atrophy was actually higher in the non-compliant group, probably because it turns out that the non-compliant group ended up needing to use steroids much more than the ones who were just using it on a schedule. So the other thing is you don't need to be as worried about topical steroids as you would think. The vulvar trigones, that area in the vestibule and on the labia minora, the prepuce, is actually pretty steroid resistant. And so as long as patients aren't going out really externally, so beyond the labiocrural fold or too much around the perianal area, you should really consider that steroids are pretty well tolerated and there's not much thinning. But do keep in mind that with steroids, patients can sometimes get yeast infections, which can complicate management, and also they can get just a contact dermatitis. So if they're using something and they're feeling worse, it may be that they're getting one of those complications of treatment. And so the treatment for lichen sclerosus is ultra-potent steroids. We keep them on it forever, using it once or twice a week. And for the most part, this ends up being a minor nuisance issue that's very well controlled. But if they don't stay on it forever, the recurrence rates are very, very high. So the other thing that we've started doing recently in the office is surgery for adhesions. And so sometimes patients get these adhesions in the vestibule and around the clitoris. And Ryan Sobel, who's my co-director, has been kind of on the forefront in our office of doing this in the office. We put on a numbing cream, we wait about 20 minutes, and then we just kind of stretch the area, and we'll use some fine hemostats to open up the adhesions around the clitoris. The surgery itself is pretty straightforward. The big thing is afterward they have to be very aggressive about continuing some sort of steroid to keep things under control. Initially, they need to come back to make sure the adhesions aren't reforming, but for the most part, patients have been very happy with this approach if they have symptomatic adhesions. So next vulvar pearl from Nyirjesy, don't miss lichen planus. On the vulva, it'll often look very much like lichen sclerosus, except that there can be erosions. It can also affect the vagina. So if you see somebody who has strictures in her vagina, or literally where the entire vagina has scarred shut, lichen planus should be #1 on your differential. Whenever I see somebody with lichen planus, I ask them about gum inflammation, swallowing problems, and also excessive teariness, because sometimes it can affect the mouth, it can affect the esophagus, and it can affect the lacrimal ducts. And sometimes just bring that to a patient's attention can help to diagnose problems that they're having elsewhere. So this again is a patient with lichen planus. You can see the big erosions and all the scarring on her vulva. And on the vulva, the overall approach to treatment is very similar to lichen sclerosus. In the vagina, we'll add vaginal steroids with or without vaginal estrogen. And if they have scarring in the deeper vagina, we'll have them either use vaginal dilators or do a lysis of adhesions for the deeper adhesions. This is really important if they want to be sexually active. So again, remember to do biopsies. This is a patient where initially you'd be thinking, oh, this might be a vulvar cancer. She's got this big ulcer, looks very deep. But if you look elsewhere, you'll see that she has similar ulcers here. This was a patient that we biopsied, and it turns out that she had psoriasis. And so keep in mind that psoriasis can definitely affect the vulva. It can be a cause of ulcerative disease on the vulva. The other thing, going back to biopsy though, is that you also need to remember to consider that you might need to rebiopsy. And so this is this patient that I talked about earlier, the biopsy that showed lichen sclerosus. 2 years later, she was still having symptomatic disease. She wasn't really responding very well to steroids. And so we did a rebiopsy, and it turns out that she had VIN there. And I don't know if she had it all along or if she just developed VIN despite being on the steroids. But if you have a patient and she has an abnormal area that just isn't responding to treatment, just keep in mind that you might need to repeat the biopsy. And every once in a while we have patients where we need to rebiopsy an area right next to where we biopsied, and we come up with a different diagnosis. So with VIN, the nomenclature has been through a number of changes. The more modern terminology now is that there's the low-grade squamous intraepithelial lesions, the high-grade squamous intraepithelial lesions. There's also the differentiated type VIN. And so with the usual type, which is a low-grade or high-grade lesions, tends to happen in younger patients. It's associated with, or smokers are more likely to get it. It's associated with HPV. and it's less prone to invasive cancer. With the differentiated, it tends to happen in older women. Smoking is not a risk factor. This is the type of VIN that's associated with lichen sclerosus and lichen planus. If you get a pathology report back and it says differentiated, it's tempting to think, oh, differentiated, that's got to be good, right? I think we're all taught that differentiated on pathology reports is better than undifferentiated, but it turns out that with VIN, differentiated is actually more prone to invasive cancer, up to maybe as many as 70% of cases. So what are the treatment options for VIN? Surgical excision, a wide local, partial vulvectomy, skinning vulvectomy. You can consider laser ablation, but no matter what the surgical approach, the margins are often positive. There's about a 30% recurrence rate, and so these patients need to be followed closely. So the thing that's changed is that for many women with VIN, imiquimod is actually an option that can be very helpful. One Austrian study compared imiquimod to surgery for vulvar HSIL. 110 patients were randomized, and they used imiquimod starting slowly and then titrating up, using it for 4 to 6 months. 80% had a complete clinical response with imiquimod, compared to 79% with surgery. No patients treated with imiquimod progressed to invasive cancer. 8% in the surgery group turned out to have invasive disease at baseline. But so it shows that imiquimod is an option for treatment. So vulvar pearls don't miss cancer. This is a patient with cancer down here on the left, or just to the left side of the perineum, kind of a bubbly thing. But the other thing that can help to decide if there's a cancer is if you palpate the area. And so if you look closely, there's almost like a ring here of raised tissue, and if you palpate it, you'll feel that there's thickening there. So time to close the lecture. And so I've been doing this for 30 years. And what are the lessons that I have learned dealing with many, many women with these complicated vulvovaginal conditions? So I think the first thing I've learned is that accurate diagnosis is the key to success. If you don't have an accurate diagnosis, you're not going to be able to help the patient because you're treating them for the wrong thing. Vaginal estrogen, I didn't have time to talk about vaginal estrogen in this talk, but it's underused and underdosed. And so remember that estrogen is a really important weapon in the armamentarium to treat these conditions. For the different conditions that you'll diagnose, I think there are very helpful guidelines from the CDC, from ACOG, and the International Society for the Study of Vulvovaginal Disease. So for most conditions, their guidelines will tell you exactly what to do. If you follow those guidelines, the majority of patients get better with treatment. If the patients don't respond to treatment, question the diagnosis. So they should be getting better with treatment. If they don't get better, then maybe it's either the wrong diagnosis, or maybe they've got a second condition going on, or even a third condition or a fourth condition. And by very patiently working away at each condition and getting each condition under control, you should eventually be able to get the patients feeling better. And then the last lesson that I've learned, and I learned this really quickly, is that you should never take these conditions lightly, because for the patients who suffer with them, they don't take them lightly at all. It really has a major impact on quality of life. So thank you very much for your attention. I'd be happy to answer any questions.
All right, thank you very much for a great lecture. Do we have any questions, Kate?
We do, just trying to, there we go. This is Jennifer Allen at MCG. Thank you so much for your talk. Can you speak to the sensitivity of trichomonas reported on liquid thin prep with PAP, and do you automatically treat when that comes back, or do you bring them in for PCR or culture to confirm?
Well, so the good news is that with PAP nowadays, they should actually be able to run the PCR right off of the PAP. So if you call the lab and tell them, could you do PCR testing off the PAP, they should be able to do it. It's not very sensitive, and from older studies looking at the PAP, the other thing is there's actually an issue with overdiagnosis, because it turns out that you can, that there can be what they call trichomonas artifact, which sometimes overdiagnoses trick. So I would not treat based on that, because you're telling her she's got an STD. If she's married, you're telling her that maybe your partner's been with somebody else. And so I think it's important to get an accurate diagnosis. So I guess there's somebody named Erin Latif who raised her hand. I don't know if you're able to speak or unmute.
Okay. Erin, can you unmute to ask your question?
I'm sorry, I did not mean to raise my hand.
Okay.
But very great talk.
Thank you.
I do have two questions for you. The first is, if you have someone that is allergic to metronidazole and you have trichomonas, what do you do in that scenario?
So the analogy is, what do you do with somebody who's pregnant, who has syphilis, who is allergic to penicillin? You treat them with penicillin by getting her desensitized. And so similarly with trichomonas, there are desensitization protocols out there for metronidazole that are actually quite effective. And so I'll send them to an allergist to get desensitized and treated. And the CDC has published a case series. I think the number was like 92% were able to be successfully desensitized.
Do you ever use paromomycin?
So I'm the one who first described paromomycin, actually. So yes, I published a few papers on it. So as a standalone treatment, it only works about 2/3 of the time. The one catch with paromomycin is that one of the side effects of it is that it can cause bulbar ulcers. Those bulbar ulcers can actually happen very quickly. And so the situation where I've used paromomycin the most, or where I still use it, is in patients with resistant trick, where we'll combine it with high-dose tinidazole. And what I do is I have patients smear their vestibules like crazy with Vaseline. And I tell them that at the first sign of an ulcer, they need to just stop the paromomycin, if possible use a douche to wash out whatever the residue is, and hope that she's gotten enough treatment, and if she stays on the tinidazole, that'll clear the trichomonas. But for allergy, I think it's safer to send her for desensitization.
Hi, Kathleen Johnson, Radiant Women's Health. Thank you so much. This has been extremely helpful. I had a question about the Saccharomyces. Since you said it's not tested for, is it also a different treatment regimen for it?
Yeah, so Saccharomyces is uncommon cause of yeast. This is my chance to tell a quick story. My wife's a nurse practitioner. She's heard me lecture. She rolls her eyes when she hears me tell this story, but she's not in the room, so I can tell this story. One of my first papers is Saccharomyces is a baker's yeast or brewer's yeast. And we described 8 women who had Saccharomyces infections, and we showed that one of them got it from her husband, who's a pizza shop owner. And we showed that her husband had the same strain on his fingers, and got written up in every major newspaper in the United States, and even got interviewed for Pizza Today. So I'm probably the only speaker you'll have this weekend who's been interviewed by Pizza Today, the trade shop journal for pizza shop owners. But to get to your question, it actually tends to be very sensitive to boric acid. So it's for treatment when we get Saccharomyces infections, we'll treat with a 1-month course of boric acid. And I got to tell my story, so thanks for asking the question.
Hello, I have a question about the medication you mentioned, paromomycin. I'm unfamiliar with that.
Yeah, so paromomycin is an aminoglycoside that was developed in the 1950s and 1960s, and there were some studies in East Germany, like in 1962, that showed that it might be effective for trick. But then that was when metronidazole came out, and paromomycin, no one ever thought about it again. And then we actually had a patient who got referred to me. This was early on, who had this highly resistant trick infection. And this is before tinidazole was available. We actually got her compounded tinidazole. Nothing worked. And I remembered that one of my ID attendings, Tom Feckett, had given me these German papers, more to see how good my German was. And so we made up a cream with paromomycin, and we cured her. And ever since then, it looks right now as though for women with really resistant trichomonas infections, the combination of high-dose oral tinidazole, 3 grams a day for 2 weeks, along with a cream that gets compounded that has peromycin, seems to be highly effective. And we've published our results with it, and other people have published their results as well. So it's an option. And if you look at the CDC guidelines, they actually have the specifics about it.
How are you spelling that?
PAROMOMYCIN.
Okay. And my second question is, if probiotics don't work, are there any other kind of holistic things that we can suggest to patients? Because sometimes they're tired of taking medications. We feel like we're on a merry-go-round. Is there anything else that we can suggest to alter naturally what's going on with the biomechanics of the vagina?
There don't seem to be. I mean, probiotics are incredibly appealing, but so far, the data is that for most of the probiotics, they don't even claim to contain the right types of bacteria. And the ones that do, we have no idea how effective they are. And the few studies that have been done, there's one really nice study of a probiotic that's in clinical trials where it got published in the New England Journal of Medicine because it was better than placebo, but the overall benefit was maybe 15%. And that one's not commercially available. So then you get to things like diet and garlic, and there's a whole host of things that get promoted to women, especially women with yeast infections, and none of them seem to be effective. And actually, like a diet is way more disruptive than just taking a fluconazole pill once or twice a week. And so patients actually are kind of relieved when they get told, well, there's nothing else, but at least we can control it. And no one's happy that you have to be on this medication for a long time, but at least you're leading your life, you're comfortable, and that's really the goal of treatment. But there don't seem to be natural or holistic approaches. And keep in mind that boric acid, it's a drug, so that's not a natural or holistic approach, but it's a drug that we use in certain situations where it can be really useful.
All right, we have one more question.
So, Erin O'Brien, thank you so much for your talk. Sadly, when we're talking about vulvovaginal disease, all of a sudden we have to talk about syphilis again. And, most of the people in the room, I think, have never seen what that looks like because it was not around, and now it's around again. So, how do we recognize that when we've never seen it, other than a picture in a textbook?
I think just keep in mind that if you see ulcers, you should remember that that's part of the differential, and especially if it's a non-painful ulcer. And then the one catch with those ulcers is that they with syphilis, the lesions of syphilis go away even without treatment. So you just need to keep in mind that if it goes away, it doesn't mean it wasn't syphilis. And then sometimes, later on, things like condyloma lata, which is a manifestation of syphilis, can look like warts. So, if you see somebody and it looks like warts, but you're not sure, doing a biopsy to see what it shows can be helpful. But I think to some degree, it's just pattern recognition. And if they haven't seen it, hopefully they've seen it in textbooks, and when they see it in the patient, it will ring a bell. But yeah, there are new diseases that come along. COVID, for example, can cause abscess disease on the vulva, so we've seen ulcers triggered by COVID. But meanwhile, old diseases come back as well, like syphilis.
Great, thank you very much. Okay, our next presentation is going to be by Bartley Miller, an update on the Georgia medical malpractice environment. We feature this lecture each year by Bartley Miller because medical malpractice liability reform remains a legislative priority, and tort reform especially this year. We continue to face mounting malpractice rates, and Georgia is